All right, we just choose TBS for clinical diagnosis. Oh, my arrow is not working.
We can see your pointer moving though.
Yes, but my slides is not moving. Oh,
yeah.
Okay.
I think it's moving.
I'm sorry. This is for guidance for early and medical management. So management of the women with presumptive clinical presentations suggestive of endometriosis, we can treat our patient only with early and quick medical management. A definitive diagnosis is not required. So I think the role of diagnostic laparoscopy is not mandatory. It's not gold standard anymore. The primary focus of endometriosis treatment should be a management of patient presenting symptoms, and treatment should be individually tailored. Oh my God. Can you show my slides?
Sure, we can share your screen again. Just give us a moment.
Okay, please help me to see. Okay. The arrow is not working well, so. Okay. Guidance for early empiric medical treatment. Medical treatment is recommended to reduce endometriosis associated pelvic pain, EAPP, for patients who have no immediate desire for pregnancy. In medical treatment, we recommend hormonal or non-hormonal medication. In hormonal medication, GOCs and GnRH agonist and antagonist, and progestin or antiprogestin was recommended, and non-hormonal medication also recommended. Hormonal treatment is more active option in treatment of pelvic pain for clinically diagnosed endometriosis. Progestins are among the first-line management option for early medical treatment. Hormonal treatment for women with suspected or confirmed endometriosis can have a beneficial effect on pain and other symptoms, and is not associated with a detrimental effect on subsequent fertility. Oral progestin-based therapy are generally a better option compared with COCs because of their safety profile. So oral progestin-based therapy are generally better option because oral progestin are not contraindicated according to patient age and smoking status and have a generally favorable tolerability profile. In Asia, unmarried patient, they don't want to take oral contraceptive pills. They prefer oral progestin-based therapy. Dienogase can be used long-term if needed. Endometriosis is considered a chronic disease. It means it required a lifelong management plan. Long-term follow-up for Dienogase, and it's 6 months in clinical study. Dienogase reduced endometriosis-associated pelvic pain and avoided pain recurrence post-surgery, and well tolerated by clinically manageable adverse effect. This paper published by Professor Remer, my following speaker. So he will talk about more in detail, I think. This is the result of 6 months therapy of Dienogase. A group of patients who taking Dienogest after surgery, and also a patient with no prior surgery, their pain score reduced significantly and maintained for 60 months. A large evidence base exists supporting use of Dienogest compared with GnRH agonist as first-line medical therapy for endometriosis. A systemic review of 9 RCT, Dienogest was significantly better than placebo and as effective as GnRH agonist. GnRH agonist buserelin and Dienogest appears equally effective in improving quality of life. A RCT of 24 weeks, Dienogest versus leuprolide acetate, pronounced improvement of quality of life measures with Dienogest. After 24 weeks, Dienogest and leuprolide acetate, they significantly improved dysmenorrhea and dyspareunia and pelvic pain. Compared with leuprolide acetate, Dienogest showed better improvement of health and mental health improvement. That is not shown here, but SF36 scale, Dienogest showed better improvement of mental and physical health. GnRH agonists may be considered for first-line therapy only in some specific situations or as short-term treatment before Dienogest. A recent guideline of NSHRE, they put GnRH agonist as a second line, but our consensus meeting, we consider GnRH agonist as a first-line therapy. However, very specific situation. GnRH should be considered as a first-line or long-term therapy only for careful selected patient. NSAID may be considered as add-on therapy for endometriosis-associated pelvic pain. Because of the limitation of NSAID, their inability to alter the disease course, NSAID are generally insufficient for treatment of patients with a confirmed diagnosis of endometriosis. So we can consider just add-on therapy. This is algorithm for clinical diagnosis and early treatment. So questions, immediate desire for pregnancy? Yes, then we can treat infertility care. No, we can start medical treatment, 3 to 6 months. Non-hormonal treatment, we can use NSAIDs, just add on, and hormonal treatment, progestin, Dienogest, can be a first-line treatment of option, can be used as long-term therapy. COC used cyclically or continuously. We prefer continuous one. GnRH agonist, first-line, short-term therapy, only for carefully selected patient. If symptom treated, we can go long medical therapy. After 3 to 6 months treatment, the patient still have symptoms, we can consider surgical management, but with caution on fertility preservation, and we have to try to avoid repeated surgery. This algorithm is the clinical diagnosis and early treatment of endometriosis in Asia. We made this algorithm very concise and then very suitable for the Asian patient. So this part is for diagnosis, I already told you, and this part is for early treatment. Early clinical diagnosis and medical treatment of endometriosis should now be considered, including within Asia. We have to do the patient-centered care. That is very important point also in Asian patient. So we proposed an algorithm for clinical diagnosis and early medical management for endometriosis in Asia. From now on, we have to further evaluate of our algorithm, and then we have to validate and discuss more with other experts in Asia, and then we have to discuss with other society. Thank you.
Thank you
This
very
is the
much,
end of
Prof.
my
Kim.
talk.
Thank you very much, Prof. Kim, for that very nice walkthrough of the consensus guidelines. I remember how much all the doctors were discussing about these algorithms, and so much of thought process went into it. Thank you so much for presenting this. We have a few questions from the audience. Yeah, I will read out these questions to you. The first question is from Dr. Pani, and the question is, what would you recommend to young women aged between 20 to 30 years who have endometriosis?
I'd like to recommend the DNOGAS progestin because their peak actually after age older than 18-year-old, the GnRH agonist is not contraindicated, but they are getting their bone mineral density. So for young women, I prescribe the DNOGAS instead of GnRH agonist.
Thank you very much, Prof.
Especially in Asian women in Korea, patient and patient mother, they don't want taking oral contraceptive pill because of the cultural background is different from Western country. So they don't want to take oral contraceptive pill. They prefer therapeutic agent for endometriosis. Yeah, that is the DNOGAS. Yep. I think, yeah.
Yeah, thank you so much for that. I think your comment about GnRH, I think that's also captured in the latest ESHRE guidelines that have come out. And I think they're also concerned about bone mineral density. Probably we'll cover that in one of our future webinars.
Yes,
thank you so much.
Shiro said GnRH agonist is second line, but we discussed about that. But in Korea, the cost of GnRH agonist is not so expensive comparing Europe or in United States. Sometimes taking DNOGAS causes bleeding. So in very specific situation, we prescribe short-term GnRH agonist to reduce the vaginal bleeding. In that case, we can use very short time, but for long time management, I prefer DNOGAS. Mm-hmm. Thank you.
Thank you, Prof. And true to what you said, you know, whenever we've seen in DynoGest studies, I think we've also presented this in the past, whenever we continue a patient on very long-term DynoGest, the chances of patient experiencing amenorrhea or decreased bleeding and decreased spotting is considerably higher. Yeah. We have another question from Dr. Sharma, which says, he's asking, when should a laparoscopy be performed to confirm the diagnosis of endometriosis?
I think we don't have to do just only diagnostic laparoscopy. When we plan to do laparoscopy, we have to do surgery for endometriosis. Just for diagnostic purpose, I don't recommend anymore. So recent ESHRE guideline, patient has symptoms and imaging negative, and still patient has symptoms, and then we started the empirical treatment, but the symptom persist, we can do diagnostic laparoscopy. So the role of diagnostic laparoscopy is very limited nowadays. Or other DIE, then we can do diagnose and then treat with the laparoscopic surgical treatment. Yeah, we also have to do that way. Just diagnose laparoscopy is no more recommended, I think.
Okay, thank you, Prof. We have another another question from Dr. Vanaja. She asks, how does endometriosis affect fertility and the ability to get pregnant?
As I explained, even early endometriosis, we call that is the subfertility, the diminished the fecundability. So that is because of a harmful peritoneal environment, and then increased sperm phagocytosis, that kind of thing. So even stage 1 or 2, the patient has subfertility, not infertile, but advanced stage, tube was blocked and then kinked and then obliterated, and then ovum, in that case, ovum transport is not, that is blocked, and then the anatomy also distorted in advanced endometriosis. In that case, the patient can be infertile. So the patient age also important. The ovarian reserve is very important. So I think even in early stage, the fertility is decreased. Yes, so we have to actively encouraging our patients to have a baby before their ovarian reserve diminished.
Thank you, Prof. Thank you for that answer. I think, last year and during Endo Summit, where you were also present, we dedicated one entire day to fertility itself, the topic of fertility. And I think we had a lot of questions then as well. And similar to the end of this year, also, we are planning to have one day dedicated to fertility and endometriosis as well. And we will work on many of these topics as well. We have one more question. I think this is probably triggered by your background, because you have background in robotic surgery and advanced fields of medicine. There's a question which is, are there any radioisotopes that you are using currently to detect endometriosis, or any new technology you're using?
No radioisotopic. No, not yet. But with the robot, I have experienced a very interesting experience with the ureter. I put ureteral catheter, and then I insert the indocyanin green to see where ureter is. Very advanced endometriosis case. She do not have any symptoms, but her one kidney was auto-nephrectomized because of endometriosis. So her one kidney was already has had no function, auto-nephrectomized state, and opposite the site, her body was very huge, and then her ureter was adhered. So in that time, I'm using the Firefly, and then I can easily see where ureter is. But until now, no isotope to detect endometriosis. So you have to see very well with a big eye. Yeah. Until now, that is the situation. Yeah.
Very interesting. Very interesting. Yeah, we have a lot more questions coming in. Probably we'll take one or two more. Do you recommend any screening tests if you are continuing Dynagest over the long term?
Oh, yes. Sometimes I check ultrasound, annually ultrasound, and then I'm asking the symptoms, and then blood chemistry. That is for the just routine checkup, not necessarily. Yet, and then also I checking up their bone mineral density. Yet, actually the level of estradiol level was 30 to 50 picogram while we are taking Dienogast. That is suitable for maintaining bone mineral density. So, however, the age of my patient is young, and then they have to get peak bone mineral density. So I'm encouraging them to exercise and then eat well, adequate calcium intake, vitamin D. I ask to them do that way, and check up the bone mineral density. But some paper, the bone mineral density was decreased during taking Dienogast, but that is just just statistical significant, not real world evidence, I think. So I'm checking bone mineral density, but their bone mineral density is not so decreased. But in some case, patient, their bone mineral density is not quite good at the beginning of the month. In that case, I'm checking their bone mineral density.
Yeah, I know that there is actually no guidelines on this. You know, you were based on just your clinical experience. If you were to give a recommendation of, you know, for doctors who want to be on the safe side of treating patients, let's say the doctor uses Dynogest and the patient is on it for long term, based on your experience, what is the frequency you would, you know, ask for a bone mineral density assessment? I mean, if at all. Yeah.
Depends on the patient to the bone mineral density. If low, I'm checking annually, but if good, not necessarily checking annually.
Okay. So you would do it at the beginning, is it? After 3 months of treatment, first one, the first assessment, when would you do it?
Ideally, I want to check a baseline. However, that is not covered by insurance in Korea. So I can just follow. But when we have to do study, we have to do baseline. Yeah, but the insurance is not covered. Yeah, so I just after 1 year of amenorrhea, we can check up the mineral density. That is the Korean situation. I don't know the other countries' situation. Yeah.
Thank you so much for that. One last question from Dr. Harun from Indonesia. He asks, this is a special case question, a patient with special medical condition. Could Dynogest be used to treat endometriosis in a patient who has had, this is post-mastectomy due to breast cancer and is on tamoxifen? Do you have any experience, or this appears to be a special case scenario? I think he has a patient such as this. One thing we would suggest is to look into, obviously, the prescriber indication, the local approved prescriber indication, and see if it's a contraindication not to use it. But Prof, what is your opinion on this?
Well, but the DNOG is also kind of progesterone. So patient with history of breast cancer, I will not prescribe progestin. Yeah. So also tamoxifen, patient with taking the tamoxifen is a kind of sum. So taking tamoxifen and then taking Dynogest is not nonsense, I think. Yet that is not working. Yeah. Cannot prescribe that way. Yeah.
Thank you so much, Prof. You have very nice answers to our questions. So we will come back to you at the end of this session, the panel discussion. Please stay online.
Okay, sorry for technical difficulties. No, I cannot move my slides. Yeah, I don't know the reason.
I guess we live in a virtual world, so we are used to this by now. But thank you very much for your excellent presentation. Yeah, we'll come back to you in a moment during the panel discussion.
Yes, I will.
Yeah, thank you. So now we move on to our next talk. Our next talk is by Professor Thomas Romer. Just to give you a bit of a background about Professor Romer, he is the head of obstetrics and gynecology at the academic hospital, Weyerthal, which is based in the University of Cologne in Germany. Yeah? He's also the head of Endometriosis Excellence Center and Endoscopic Training Center since 2009. Professor Romer has been a board member, former president of the German Society of Gynecological Endoscopy, and he is also the founding member of the European League of Endometriosis. Professor Romer has published more than 350 papers. He has been involved in writing over 50 textbook chapters and over 35 monographies. He's written a lot on bleeding disorders, hysteroscopy, laparoscopy, endometriosis, uterine malformations, endocrinology, menopause, and whatever you can think about. He's a very well-respected, distinguished professor, and we are really honored to host him again. Professor Romer, welcome to the talk, and the floor is yours. You may present your slides now. Thank you.
Dear Stephen, thank you for the nice introduction. Thank you for the invitation, and I'm happy I can share some clinical experience. especially our experience with Dynogest. Possibly you know Dynogest is a drug that was developed in Germany, and so we have a long time of experience with this specific drug. And it was also mentioned in the lecture from Professor Kim. We have also published some data about the long-term treatment. And I will today share not the specific data from studies, only some 6 case reports from typical cases in our clinical practice. The first case is a 18-year-old patient. It was also a question in the lecture before. She has pelvic pain, she has a dysmenorrhea, she has a dysgeusia, and it's typical in Germany, the patients take sometimes CUCs in a very early age, but the pelvic pain was reduced. But we know also from the CUCs we have sometimes side effects. In this case, it was a headache. During the clinical examination, we find the painful bladder and Douglas. We find a normal sonographical findings. It's typical findings for peritoneal endometriosis. And so it was in our guidelines also changed in the last year. In the first line treatment, we use Dynogest. And it was also mentioned in the guidelines in the consensus meeting we have in Asia. It's also changed in the last years, a paradigm change. We can do a clinical diagnosis. It's very easy to do it in deep infiltrating endometriosis and in ovarian endometriosis. It's a little bit more difficult in peritoneal endometriosis because we have only some clinical examinations, we have a history, but we have no sonographical findings. But if we are sure in this case it would be endometriosis, we can do a primary medical treatment, especially in cases we have no success with the use of CUCs. And it was also shown an algorithm. I must not repeat it, but it's very important to do a very good evaluation of the presence of symptoms and of the history. And also it plays sometimes a role, familial history. So from all these 2 aspects, you can be safe. It could be endometriosis. And also for the question before, it would be, have you not success with a medical treatment, you can always change to do a laparoscopy. But the first step should be with the clinical diagnosis to do first line medical treatment. And in this case, it was very successful. The problem at the beginning, it's very important to explain the patient, is you have in the first 2 or 3 months unscheduled bleedings. After the most of the patient has after 3 months no bleedings, and it was important for the patient. She has a very fast pain reduction. So it's also very successful treatment because we have very fast effect of treatment. And she has also a reduction of the dyspareunia. And we do a yearly clinical check in these patients. So we have not so a problem, not so a focus on the bone mineral intensity in patient older than 18 years. I believe it's also from the studies, we know it's a little bit difference between European and Asian women in this topic. Patient was very satisfied, and after 2 years, she has spottings. And when the patient has bleedings during the treatment with Dynogest, you should measure the endometrium thickness. In the most of the cases, it was thin, like in this case. And we make 1 week break of intake and start again. And the bleedings stopped in the most of the cases. And in this patient, we can continue the treatment until the patient will be pregnant. So it's a good solution for this young lady. And we know also from lots of studies, it's one of the real world setting study from Russia. You can see here a very successful, also in a real world setting, a very successful reduction of the pain. And it's the most important point for the patients. And it's also sometimes a question, have we a higher success with Dynogest when we do a clinical surgical diagnosis before? And from the Envision trial, you can see it's no difference if you have a clinical diagnosis or you have a surgical diagnosis. The success of the treatment is the same. So it's not benefit for the patient if you do a surgical diagnosis. diagnosed. It was one of the questions in the session before. The second case, it's also a typical case, a patient with a recurrence of endometriosis, a 28-year-old patient, laparoscopy 3 years ago, the endometriosis was removed. She has a successful pregnancy 2 years ago, and she come back with the same symptoms. And the patient, and the most of the patient know, oh, endometriosis is back. So we have the question of the patient, well, do a laparoscopy again, or we try a medical treatment. The decision, as you can see here, the lesions at the laparoscopy 3 years before. And the decision of the patient was for Dynogest. And you can see we have here also a very fast reduction of the pain. At the first 90 days, we have sometimes bleeding problems, but it's very important to explain the patient. It could be, it's not a sign of the recurrence of the disease. It's very important to talk with the patient about this problem. After a while, the most of the patient will have amenorrhea, and you will see also in this patient, she has just now 5 years amenorrhea and is very happy. She needs not a laparoscopy again. And we know from all the studies, that's an example here, if the patient has not received a hormonal treatment, she will have a very fast recurrence of the disease and need a new surgery. And this is, in my clinical practice, the most important point for the motivation for the patient to take a hormonal treatment. The third case, it's also a typical case, patient with ovarian endometrioma on the left side, but she has pelvic pain and also dyspareunia. She has no hormonal treatment. And because of the pain of the patient, it was the decision to do surgery in this case. We removed the endometrioma. You can see here, it was very easy. And it's always very important to make a careful decision between surgery and medical treatment in ovarian endometriomas, because we know also if you are an excellent surgeon, you will have a little bit damage on the normal ovarian tissue. And so we can also not say it's a really cut-off level for the size of the endometriomas. Also in the guidelines, it's sometimes 3 or 4 centimeters. It depends from a lot of things. It's from the age of the patient and especially from the clinical situation. In some cases, it's necessary, like in this case, from the clinical situation, to do a surgery. But it's very important to prevent a second surgery in this patient, because all surgery on the ovarian is a damage for the fertility. So it's very important to give, especially patients with endometriomas and we want a future pregnancy, to give Dynogest. And in this case also it works very well. And we know it's a selection of a lot of studies we collected. It's only in 2% of the patient, it's depend from the follow-up time, you have recurrence of endometriomas. So it's very easy because the recurrence of endometrioma you can measure by sonography, so it's very objective data. We know from the other side, we know if the endometrioma are not so big and the pain is moderate, you can also try to treat the endometrial cyst with the Dynogest. You can see from this study, we have a reduction in the size. If you stop the treatment, we have an increase. So it's not always possible, but in selected cases, it could be also in the first line treatment to use it. And one of the most important studies for the use of Dynogest for prevention of recurrence of endometriomas is the study from Otter from Japan. And you can see here, it's also very important for the patient. In the 5-year studies, I explain also most of my patients with this study. We can say, if you do nothing, you will be recurrence of 70%. If you do a Dynogest treatment, you will be a recurrence of only 4%. So it's very impressive also for the patient and the motivation to take post-operative adjuvant hormonal treatment with Dynogest. Endometrioma is a very special situation because we have, with the surgery, we can do a lot of damage for the ovarian endometriosis. So it's always a careful decision between surgical and medical treatment. And in many cases, we can also use Dynogest in the first-line treatment. On the other side, in all patients with endometrioma, we should use it for the prevention of the recurrence, because in the recurrence, if you do a surgery for the recurrence, you will have a higher damage of the ovarian reserve, especially in young ladies. The case 4, it's a typical case for long-term treatment. Patient with a first consultation in the center. She has laparoscopy before, and in the time before we have Dynogest in Germany, it was 2010. It was used CUC containing adenylyl estradiol and Dynogest. It's called Wallet, and the patient has a reduction of the pain, but CUCs are better than nothing, but not so good like a progestin treatment. And so when Visan was available 2010, we changed in this patient. She has sometimes spottings when she forgot a tablet, so it's sometimes good for the compliance to remember to take it every day. And 2016, she has 6 years. She has a little bit hot flushes, but the estradiol level was in the normal ranging. And in the last year, after 11 years treatment with Dynogest, we have finished the treatment because the patient was in the menopause. So you can see it's a long time, more than 10 years. We can prevent a surgery by a long-term treatment with Dynogest in this patients. So it's very important and a good explanation and motivation for the patients. And it was shown by Professor Kim. It's one of our study of a 5-year study was published 3 years ago. And the most important results, in my opinion, is because of the discussion of the bone mineral density, the measurement of estradiol. You can see the estradiol level was in the range the so-called therapeutic window between 20 and 50 picogram per milliliter of estradiol serum level. So we have a good suppression of the endometriosis, but we have no negative effect to the bone, and it's also a long-term treatment of 5 years. It's a very important result, and really new data. We have collected our 10 years data. You can see it's a small group of patients, but we have a sustain of pain reduction. Some patient had surgery for other reasons, and we have also very excellent estradiol level in a good range. And only 2 patients had in this long-term treatment sometimes mood changes. Sometimes I treated with additional transdermal estradiol spray. So it's only sometimes a temporary treatment, but you can continue for long-term with the Dynogest treatment. It was very new data. At the end, some specific cases. One case of bladder endometriosis, patient with recurrence periodic hematuria, and she has in the urology transurethral endometriosis resection, and it was clear it was not a solution. Patient come back with pain in our center because she don't want the surgery at this time point. We give the patient Dynogest for 5 months because this was a waiting time for the surgery. It's not fixed treatment regime, and after the 5 months we resected the bladder, and the patient received the postoperative treatment also with Dynogest. You can see here the cystoscopic findings at before the surgery, before the treatment with Dynogest. You can see a lot of a big area of endometriosis with a lot of vessels, and after it's laparoscopic findings at the first laparoscopy, and it's a cystoscopic finding after 5-month treatments. You can see a reduction of the area of the endometriosis in the bladder wall, and also reduction of the vessels. And so the idea was you can when we do a resection, but the area we must be resected was smaller. So it's very important for the postoperative bladder volume for the patient. So it was also an advantage for the surgery. You can see here that in the brown area with the endometriosis in the bladder wall. And so we have discussed it with our colleagues from our countries, from Canada and from Brazil, and collected the data, presented also at the World Endometriosis Congress. So it seems Dynogest is very effective in bladder endometriosis. It's possibly by the metabolism of Dynogest in how the renal elimination. And in this study was only in 50% that the surgery was in the bladder was completely treated by a hormonal treatment. It's also some other publications from Italy and from Japan. We confirmed our results. And the last case, it's a patient also with a long history of endometriosis, and she take also CUC before Visan was available in Germany. When she takes Visan for 4 years, and when she desired a pregnancy, finished the treatment with Visan, and at this time point, we removed the extensive endometriosis because it was a good time point. And you can see here, she has a bladder endometriosis, she has the umbilicus endometriosis, she has endometriosis on the ovarian with adhesions, and she has also bladder endometriosis. Surgery was without complication because she has a little bit waiting time after the surgery, but because of the bowel resection, bladder resection. And when she was treated with ovulation stimulation and she was pregnant, cesarean section. It's also sometimes good to have a confidence on patient will be pregnant. It's a very extensive type of endometriosis with a lot localizations. So I hope I can present on this cases. The clinical diagnosis is possible, and the first-line treatment with Dynogest is effective. So today is not a question which patient receive a medical treatment. It's more in this patient I have really indication for laparoscopy in the first-line treatment. And we know from our just now experience from 12 years, and I have presented new data from the 10 collection of the patient. Long-term treatment with Dynogest is possible and prevent recurrence, and we should use it. So it will be changed. I love to do surgery, but we should. It's very important we do the surgery on the right patient at the right time. And endometriosis, it will be more successful. And medical treatment plays a very important role because we don't forget. Endometriosis is a chronic disease, and one of the cases, patients not the perfect solution. So always it's important to check if a medical treatment is a better solution for the patient. I hope I can give you some details of our clinical experience. And thank you very much for your attention.
Thank you, Professor Romer, so much for your talk. I think we have so many questions here, so I think we may not be able to answer everything at this moment in time. So we will just keep it for the panel session. So if I may ask you to just stay online, yeah, we will come back to you after Professor Zhang's talk in just about 25 minutes time. Please stay on the line. We will join you back again.
Okay,
yeah, thank you very much for the audience. They've been posting a lot of questions. There's a lot of activity here as well. Some very interesting questions coming in. We also have some questions coming in from the parallel platforms because we have other platforms that are also broadcasting this event in different languages and on different channels as well. So we have those questions as well. Meanwhile, we will move to the next interesting part of our presentation. So audience, you have seen the Asia Pacific guidelines that Professor Miran Kim had presented, and you had seen her perspective. The Asia Pacific guidelines was a guidelines put forward after 9 countries came to propose the guidelines after a thorough review. Then you also saw the European perspective from Professor Romer. Now we also have another interesting perspective from China. As you know, China is a huge medical body as well. They have a lot of patients. They do a lot of research as well. And it's a very interesting thing to have a perspective from China and to see how they are managing endometriosis and what do their guidelines say. Yeah? So with that, I will provide an introduction to our next speaker. Our next speaker is Professor Jinmei Zhang. He's a MD, PhD. He is the Chief Physician and Director of General Gynecology at the Department of ONG Women's Hospital at the Zhejiang University School of Medicine in Hangzhou, China. Dr. Zhang has been involved in translational and clinical research, and he's been involved in developing novel treatments for both endometriosis and adenomyosis. He's also been involved in novel treatments such as double flat adenomyomectomy for adenomyosis. He's designed several probes as well for surgical treatment of deep endometriosis. His basic research is mainly focused on mechanisms of endometriosis-associated pain and studying how to subdue this pain. Yeah, he's been supported by grants from the National Key R&D Program of China and the National Natural Science Foundation of China. He's a regular contributor to peer-reviewed scientific journals, including Human Reproductions, Fertility and Sterility, and other very well-reputed international journals, and he's published over 100 scientific articles. Yeah, and he's also authored a book on adenomyosis, and which has been published by the People's Health Press in 2018. We thank Professor Zhang for providing us with this exciting talk. To minimize the technical difficulties, what we did was we recorded this part of the session. He's also present live to the attending the call. We will come back to him to take questions live after this presentation. Hello, Prof. Zhang. Thank you very much for attending the call. We will now move to the presentation.
Many thanks to the companies and invitations. It is my pleasure to have a lecture in this international meeting held by Beer Company. And also thanks to the organizing meetings. I'm very glad to have the opportunity to interpret the third versions and the 2021 and Chinese guideline for diagnosis and treatment of endometriosis. I'm Jinmei Zhang, and from Women's Hospital, Zhejiang University School of Medicine, Hangzhou, China. Hangzhou is a very famous big city in China. There have been the centrally owned popular seeing private cities in heaven. There is a paradise on earth. There's Suzhou and Hangzhou. So we will warmly welcome you to have opportunity to visit Hangzhou in the future. It is 6 years since the second versions. Therefore, this version is based on the previous versions, combined with the progress of the clinical and basic and transformations research in recent years, the accumulation of the clinical experiences. So in view of the current literatures and clinical data, generally speaking, recently there's still very few documents that can find the strong evidence to support these visions, such as RCT and just as the endometriosis guideline of the European Society of Human Reproduction and Embryology. We just released in March 2010. So therefore, this visions is made by Chinese experienced experts under the leadership of Professor Ren, Chinese Obstetricians and Gynecologists Association. Obviously, these versions have Chinese characteristics. So compares to the previous versions, this version has many and significant changes. Of course, we list of the level of evidence. It means and focus on following and 5 aspects. One is early and clinical diagnosis and early And the second is patients' clinical problems or issues such as age and fertility requirements. And the third is the diagnosis and treatment of endometriosis combined with adenomyosis. And the fourth is the patient education. And the five is disease and prevention. And first of all, we know is the definition and the prevention is similar. Endometriosis is very common and benign and chronic inflammatory disease. That's the main and manifestations of pain, infertilities. About 190 million women worldwide and suffer from endometriosis, and seriously affects women's quality of life. However, the cause of endometriosis remains unknown, no matter how hard we try. So due to delayed diagnosis of endometriosis, so it will cause aggravation of the disease. So the decrease of the use of delayed and early treatment is very important. From in view of the early diagnosis, so the clinical and diagnosis it means that we have no pathologies and pathology conforms. The clinical and diagnosis we based on the clinical symptoms, signs, and images and lab tests or others. So for the clinical symptoms, example such as pain, so they have a variety of the pains. And here are listed and four other types of dysmenorrhea and chronic pain and dyspareunia. So unfortunately, plus more than one of the pain symptoms, and maybe can make a clinical diagnosis. So for the gynecological examinations, if we use the speculums, so you can watch as nodules in the posterior fox, or you can palpate nodules in the uterosacral ligaments, or palpate as a mass. So for the images, and we often first use the ultrasound because of ultrasound is the low cost and the convenient. Of course, if some patients and they were suspected and cancer or deep endometriosis, so will be under the MRI or biomarkers and other special tests. So for the surgical and the treatment of endometriosis is similar to the previous versions. Uses the ASRM. Of course, as the type or subtype of endometriosis is similar to the previous versions, and superficial endometriosis, ovarian, and deep endometriosis. So more to the second is based on the clinical issues such as ages and fertility requirements. First of all, we treatment by the ages. For the reproductive age of the woman with endometriosis, this is a routine and endometriosis treatment, such as pain treatment, treatment, or long-term treatment. For the long treatment, we need a drug. So how to maximize this and the effect of the drug therapy is very important. So because of the endometriosis cannot be cured, and after surgeries, the recurrence will be inevitable. So how to maximize the effect of the drug and the therapy is very important. And now there's 5 kinds of the drugs, but normally using the China, there are 3 many kinds of the drugs. such as OCs and progestins and gonadotropins release hormones agonists. Here is endometriosis associated pain of the clinical and pathway, and for this and the pathway, we add this as a long-term. This is a change. So this is a principle for the endometriosis associated pain. For example, the ovarian cysts maybe for the diameters are more than 4 centimeters and needs for the surgery, of course, and we will be combined some pain symptoms or others. So these are combination, not for only for the ovarian cysts and for the diameter more than 4 centimeters. This is for the Daniel gas, the Jewish mechanism and for central or peripheral and action. This is for the 2 milligrams per day, and that's very, very effective for treatment of endometriosis for the long-term treatment. So the mode and the management of ovarian cysts and treatment. For the treatment, we only the 2 choice: drug therapy and surgery therapy. And this is for the indications for the drug therapy and surgical therapy. So just as similar to the endometriosis, actually the pain less than 4 centimeters for the diameters or more than 4 centimeters. And for the patients with the fertility design in the future. So if the patients needs the surgeries, we need to evaluate ovarian reserves and reproductive and fertility. So here's list some and principle and such as repeated surgeries, and it's not recommended for recurrences. So evidence suggests simply excision of the unilateral ovarians with a diameter of 6 centimeters does not significantly improve the natural pregnancy rate of the patients. So for the recurrences, how to see is we avoid so is the endometriosis with infertility and clinical pathway. Like we add the EFI more than 5 and less than 5. This is for the pathway. Another is and age more than 35. And this is the treatment principle. Of course, they have noted for important patients aged more than 35 years or other indication, then they need to use IVF. And for the DI treatment, deep endometriosis is very, very difficult for the clinical treatment. So we need to add multiple, MDT for the treatment. And here's the list and indication of the Ds for the surgeries. And there's 3 points. And also a list for the urinary endometriosis indication for the urinary tract or blood endometriosis. And so how to make a plan for to reduce the endometriosis recurrences is very important. So sometimes based on age, of course, and it depends on the patient's requirement. Here's there are 2 patients with fertility requirements and the patients without fertility requirements. So this is it's according to the patient's requirement. Here is a recommendation to evaluation of ovarian regimes and fertility foods, of course, and for the patients with infertility. So treatment for the patient with the infertility is a priority, is priority for women with endometriosis. Of course, and the recurrences is inevitable. So the incidence of the recurrence is very higher, and average year 10%. So 2 years and means recurrence rate will be 20, and 5 years will be 15. So reduces recurrences are very important, of course, and many factors can affect recurrences. And here and the risk many risk factors, such as young ages on the notice and remain after surgeries. So a lot of risk factors can affect the recurrences of the endometriosis. So how to reduce the endometriosis recurrences? Here, risk and some drugs. Of course, the drugs are the main the solute and the main kinds of drug here. And use the long-term drug therapy, of course, can reduce the recurrence of endometriosis. So how to preserve or persist the long-term and drug therapy is very important for the reduces recurrences or and preserves fertility. So and if we use a drug, a long-term and drug therapy, so we need to select a good drug. So Dino and Jest is good efficacies and good tolerances. So and if the patient and uses the orals and then the Jest and after surgeries, so and the recurrences is reduced. Here's a risk and and the Jest has a similar and effects as and GLJ plus antibiotic therapy followed by the OC. Of course, and the OC and the progestins, and for the women with fertility requirements, is how maybe and there's the efficacy as similar, but the side effects is different. OC, because of the containing estrogen, so the side effects will be more and more than the Dino-Jest. So compared to the expectant, so after 24 months following the surgeries, there is no recurrences of the use and Dino-Jest. Of course, and recently in British Journals of the Gynecologists, and they say that and long-term management and there are two kinds of drugs can be beneficial for the patients. One is the progesterone, and the other is COC. So for the surgical therapy, this is the last step because and for the endometriosis, and the idea is and one surgery in one life, but sometimes it's seldom to do it. So and there and the three modalities of the surgeries is depend on the ages and patient and pain symptoms or fertilities and requirements. And for the adolescent endometriosis and for the treatment, they're similar to the adult and women's, but you need to and only as old as possible to use the drug therapy and long-term and follow-up and management. Because of the delayed diagnosis, so if you use drug very, very early, so can and reduce or shrink the time of the diagnosis. So this idea, I think, is similar to the international views is simple. So if the adolescent endometriosis, how to say is drug will be fail, so and will be needed to surgery. So you need to conserve and socialize. And for the drug, so for the adolescent, we need to use and select some suitable drugs. So for the adolescent, maybe the CUNG is good. Of course, progestins and maybe you use. And for the perimenopausal endometriosis, because of the menopause and women with endometriosis, the age is old, and they have the risk for the malignant transformation. So we tend to perform the surgery. But here is a risk for the long-term management of the perimenopausal endometriosis. 3 items: pay more attention to the risk of the malignant transformations, needed to active surgeries. So after surgeries, we need to long-term and follow up. Of course, and in addition to the pelvic endometriosis, we found extra pelvic endometriosis, such as the scar endometriosis or other and the layer pelvic extra abdominal endometriosis. This will be the individual's treatment and moved and to the combination of the endometriosis and with adenomyosis. Endometriosis and with adenomyosis, if both are combinations and they cause the symptoms aggravations and declines fertility further. Of course, some abdominal uterine bleeding was seldom seen in endometriosis, but both will be more abdominal uterine bleeding symptoms. So the incidence will be vary from the 21.3% to 91 to 1%. So treatment and of the patients with endometriosis with adenomyosis for the treatment is depend on the disease, both which one is a major for hair. If the adenomyosis is a major, hair is and endometriosis is a major. For the adenomyosis and with endometriosis, adenomyosis is the main disorders. So we follow and the clinical pathway for the adenomyosis, and we have 20 exports concerns in China. So and following is a clinical pathway. So if the endometriosis is the main disorders, so following and clinical pathway for the endometriosis, if both was severe, so we only do is individualize. And for the patient with adenomyosis and with and infertility combined with endometriosis, so also requires full fertility management and long-term drug management. So after fertility is completely. So and for a woman with no fertility requirement in the future and slight simple for the treatment, we can add in intervention and therapy. For example, high intensity and focused ultrasound or other treatment like UAE. Of course, and in endometriosis and need a long-term management, but during the management, more attention and should be paid for as a risk of malignant and transformation. And here's the risk and factors for malignant transformation, and such as age, more than 45 years old, and post-menopausal, and whereas endometriotic cyst is too large, more than 8 centimeters in diameter. So pay more attention for the risk. Now we talk about the patient education. Of course, it is very, very important for the patient to understand endometriosis, because the patients and understand endometriosis, facilitate follow and management. So education, educated patient is very important. Of course, we need the contents to educate patients to achieve the goals of the long-term management and follow-up. And the last is preventions, of course, and the good prevention is to early diagnosis and early treatment. In addition, early detection is also very important. Like here is this one is reduce the formation of the endometriotic lesions, and two, they control the disease progressions and avoid or delay surgery or delay surgeries. So for the summaries, treatment and goals is to reduce and eliminate the lesions, reduce and eliminate the pain, improve and promote fertility, reduce and avoid recurrences. This is the same same as the previous versions. The treatment principles, the long-term management, and treat patients, and is according to the patients and clinical issues, age, fertility requirement, and early diagnosis and early treatment as soon as possible. So pay more attention to and risk for malignant transformations and the long-term drug management and comprehensive treatment should be performed after conservative surgeries to prevent recurrences. So patients with endometriosis should be regularly followed, and patients with a high risk, of course, we emphasize for the risk for the malignant transformations, because the endometriosis up to now, the causes remains unclear. So I just read the 2020 of the European Society of the reproductive embryologists, the guideline, and they said that the evidence, strong evidence, although progressions in 6 years, but strong and evidence to support guideline is lack. So we need to leave some and a lot of questions, and for the basic and clinical research. Thank you for your attention.
Thank you, Professor Sun, for that very comprehensive talk. We really liked how you covered all of the patient's aspects as well. You split it into 5 different parts, and you very nicely included the patient as well, and the patient education and the needs as well. Thank you very much for that. We will now move into the panel discussion, which is the last section. We have very little time, but we will take as many questions as possible and present it live to our panel session here. So welcome back speakers, Professor Kim, Professor Romer, and Professor Zhang for this session. Professor Romer, I have one question for you, which is, I think, following up on some of the cases you had presented. This is also a case I think one of the doctors is encountering, which is if endometrioma was diagnosed together near full-term pregnancy, what will be the treatment? What will the treatment look like?
In the pregnancy?
Yeah, if endometrioma was diagnosed together with near full-term pregnancy, what was the approach like?
The patient is pregnant and has endometrioma, is the right question? So yes. You can do nothing, you wait and see. So the only, you cannot do hormonal treatment. The only situation, if you have a clinical situation, the patient has extremely pain, or you have a torsion of the ovary, you must do a surgery, and it's very difficult, but we can do it with a laparoscopy, and we use in my department a special method, the so-called gasless laparoscopy. It's a very excellent method for to do laparoscopy in the pregnancy. So it seems important if the patients, the question is if the patient has a big endometrioma, you should find the solution with a medical treatment or a laparoscopy treatment. The patient should not go in the pregnancy. It's like with fibroids, so you should have good condition at the ovaries and uterus before the patient give the advice you should be pregnant.
Okay, thank you, Prof. I think following up with one of the long-term data you had presented, there is one question from Dr. Dogra, and the question is, how long can Dynogest be taken and what is the maximum dose?
In the most application, the 2 milligrams are enough, and we have experience until 12 years, so it's not in all patients necessary, but it's possible. The only you should be careful with the bone mineral density, because I mentioned it's a little bit different obviously between European and Asian women. So I believe from the studies also from Korea, I know it's a higher risk of bone mineral density changes in Korean women when in Western Europe. So we have not so a big problem only in adolescent patients. It was mentioned. Otherwise, it's not reason to stop the treatment if the patient has no side effects and you have a efficiency. The only sometimes it's a little bit difficult to stop the treatment in the menopause, because it's a little bit difficult to estimate is the patient really in the menopause, because we have also suppression with the estradiol by Dynogest. So it's sometimes a little bit difficult, the clinical decision when I stop the treatment. So in my opinion, in Western Europe, we have a age average on menopause on 51. So in my opinion, I say mostly I check after 1 year after the average menopause with the patient is 52 and check the estradiol, and we have a really good suppression with below 20 picogram per milliliters. So I can say it's safe and stop the treatment. So it's a little bit difficult, but we have not so a lot of experience, but it would be also interesting topic for the future, for the next consensus paper.
Okay, thank you so much, Prof. Just a follow-up question. I think this comment was made by Professor Chapron in one of our previous talks, and the comment was, endometriosis is a lifelong disease. The woman is born with a uterus and she dies with the uterus. Therefore, you have to look at endometriosis as a lifelong condition and continue to treat it. So I guess what you're saying is continue treatment as long as possible as a lifelong condition until there is menopause and you see a change in hormone or a drop in estrogen. Is the understanding correct? Yeah,
it's correct. Mm-hmm. But it's also important. It's a lifelong. It's also important if you stop the treatment in the menopause. It's also some special condition you must take care of, or endometriosis. If you do a hormone replacement, it's also a specific condition. So it's not stopped with the menopause. If the patient have other symptoms, and we will give treatment for hot flushes, for instance, you also must always remember the patient has endometriosis. If she has a severe endometriosis, it's also a specific condition. You can also reactivate it, endometriosis also in a 60-year-old patient. So it's really true. It's a lifelong disease.
Okay, thank you, Prof. The next question, Professor Miran Kim, for you. Do you have any experience of treating scar endometriosis with Dynagist?
Yeah. Actually, I excised those patients. I didn't see that many patients, but at the time I already excised. And then after treatment, I add Dynagist treatment. So, but Dr. Ramos showed some umbilical endometriosis. He treated with Dynagist, I think. Yeah, but before I usually excise that endometriotic lesion, and then I followed post-operative Dynagist treatment because the pain was very severe. So patient want to excise that scar. So I excised and then post-operative Dynagist treatment.
Thank you, Prof. Follow-up question, you do a lot of surgery. Is there any experience where you have done an ultrasound-guided endometrial cyst aspiration and then started them on a progestin like Dynagist?
Yes, but when patient did surgery, I prefer excise of that endometriosis lesion instead of ultrasound-guided cyst aspiration. And then we put the 100% ethanol. We called that is the sclerotherapy. I use that treatment for recurrent endometriosis and then very hard case to perform surgery, repeated abdominal surgery history. That kind of situation, I do sclerotherapy. But in Korea, many local clinic and then many gynecologists, they prefer sclerotherapy. But the after sclerotherapy, they are reported very high recurrence rate, and then after sclerotherapy, when laparoscopy was performed, there was intensive adhesion. So I am not fond of sclerotherapy, but some case I do. Yeah.
Thank you, Prof. Kim. Professor Cheung, this is a question for you. Let's say this is a question from Dr. Thompson from Indonesia. If the patient is started on Dynagist or GnRH and the results are already good, would you still do lesion excision and adhesiolysis in endometriosis patients?
Thank you. No, I started with the treatment for tertiary dystocia GnRH. This is just very effective. So that would be short tubes and continue use Dynagist, not use the surgery to excise the lesions.
Thank you, Prof. One more question about this is regarding fertility from Dr. Rao. The question is, does GnRH agonist before IVF improve the implantation rate?
No, this is the previous versions. We think maybe can improves the clinical clinical practice later. But now this we know this is no. So we seldom use the drug before the LT or this is similar to the just published in 2020. So no drug use. The drug is no beneficial to the clinical and the pregnancy rate or both life relate. Okay.
One more question is, what is the connection between CA125, the biomarker CA125, and endometriosis? What is the level of associations?
This may be quite different from the Western and to the to the Chinese overseas Asians. we in China we often use the C125, to evaluate or help to diagnose the endometriosis. But nowadays we can change by marks. It's just still use, maybe the use for and monitor to the efficacy of the drug, the therapeutic efficacy. So not for the diagnosis.
Stefan, may I add one more comment about that?
Yep, sure.
Yeah. For diagnosis, CA125 very limited value for endometriosis, but in my own data, I published in 1,200 cases of gynecologic surgery. In case of adenomyosis, CA125 level was very high. So the role of CA125 is for the monitoring of the recurrence, not for diagnosis of endometriosis.
Thank you, Prof. Kim. Thank you, Prof. Chung. So we have a lot of questions actually, but we are short of time as well. So we'll take 2 more probably or 3 more in the interest of time. Thank you everyone for showing so much of interest in the talk. Professor Romer, the question to you, some of the guidelines for surgery mention keeping 4 centimeters as a cutoff for surgery in endometriosis cyst. Would you still consider a smaller cyst incision and excision if there is symptoms of pain?
I mentioned it. It's not only the size of the cyst, so it's also in the guidelines. It's not of evidence-based data, so it's 3 or 4. You have patient, you have a 6 centimeter cyst. No other signs of endometriosis. You can do prefer a medical treatment, and in other patient he has a lot of pain, and in the most of the cases you have not only ovarian endometriosis, it's necessary to do a surgery. So I mean it's always in every patient the individualized decision. So, and it's also dependent of the age of the patient. If we have a perimenopausal patient, it was mentioned by Professor CUNG, we have a higher incidence of malignant transformations, so it could be an indication. It's a lot of things we must do an individual decision, and the size is only one point from a lot of our points he influenced our decision.
Thank you, Prof. Romer. Professor Zhang, one question for you. Is it appropriate to call endometriosis a lifelong disease because it disappears with menopause? How do you see it in China?
It's similar to the Asian guideline and similar to the 2020. We need the long-term management and drug management for until the patient has got a pregnancy and want to get a pregnancy or until the menopause. You see,
Thank you, Prof. Zhang. Prof. Kim, one last question to you. You are the chairperson for the endometriosis guidelines. What can countries do from their own perspective to adopt these guidelines? Can they do something locally? Yes. What can be done locally? Would you suggest? What is the next step to your? Yes. What's the next step to your guidelines?
I have to discuss with Korean Society of Endometriosis also, and then we have to discuss the Asian Society of Endometriosis. So we have to develop and then discuss more, and then we have to publish our Asian guideline with many Asian society. Yes. So actually we have to have our own guideline, not others, Europe's, not Asia. So not Asian population is in many aspects different. Yes. So we have to take care of our own patient locally.
Yeah, thank you so much.
Sorry, can I ask Dr. Keith and how many countries the Asians not included in China? So I just asked Dr. Keith how many countries in your continues So consensus was the Asians diagnosis and the treatment of the endometriosis.
It was 9 countries.
Nine, and then France, and then Professor Remo, and then Professor Chaperon was invited at the time. So I'm sorry, we couldn't invite the expert from China.
But I think there's China is a very big population here. So I just ask. So okay.
Yes, Prof. Thank you very much for the feedback. We will definitely include you. I think 2019, China was not very active in that scene, at least in terms of the partnership. So definitely we will keep this in mind for our future collaborations, and we will definitely make you part of our any publications in the future. One last thing for our audience before we drop off, we do have a feedback form that if you could just click on your screen, the feedback form will come up any moment now. If I can ask our admin to bring up the feedback form. Yeah, so please do select your answer, give us some feedback so we can create better better events for you in the future. We also have one more event coming up in October and November or somewhere there, which is a collaboration with CUNG. It's going to be a 3-day event, and we are going to cover endometriosis, we are going to cover ESHRE guidelines, we are going to cover fertility and many other topics. So we will look forward to hosting you again. Meanwhile, should you have any questions, if you want to request for materials, if you want to request for publications related to this talk, then please reach out to your local Bayer representative. They will be able to provide you with all the materials that you want. Having said that, we will now close the poll, and we thank you very much for participating in this event. And in the interest of time, we'll close this event. Thank you so much to the speakers, Professor Romer, Professor Kim, and Professor Zhang. Thank you very much for taking the time and attending this call. Wishing you a very good day ahead. Thank you.
Okay. Thank you very much for having me.
Thank you very much.
Thank you very much.
Professor Remo, I have a question to you. Can you stay online?
The terms.
Professor Remo, I have a question. Can you stay online?
Yes.
Yes. Thank you very much for your 10 years experience about the guest.